we're going to spend some time talking a little bit about why we tend to miss acute coronary syndrome. Acute coronary syndrome certainly is one of the most common misses in the med-mal arena, and one of the things that we worry the most about. And it's an area of particular interest for me in that I've had an opportunity to review quite a few of the cases that are out there on missed acute coronary syndrome. And this entire lecture is based on what I've learned in reviewing all of these cases. We're not just going to talk about why we miss acute coronary syndrome, but we're actually going to spend a lot of time in this lecture talking about why we tend to get sued for missing acute coronary syndrome. And for those people out there that work in areas that are not imposed or not subject to a lot of litigation, I think the things we talk about in this lecture are still going to be very, very relevant to all of you, because litigation in the United States is very largely based on mistakes that are made. Not entirely, but that's what this lecture is all about. What is it that accounts for a lot of the mistakes that we make in acute coronary syndrome? Why is this an important topic? Well, I'm probably preaching to the choir here. We all know that acute coronary syndrome is very high risk. To me, this represents what real emergency medicine is all about. It's very high risk, but if you do everything right, there can be a really, really good outcome. So in many cases, it's all or nothing. You play your cards right, there's a great outcome, but if you miss it, there can be an awful outcome. When you send home a patient with acute coronary syndrome, for example, accidentally, mortality can be anywhere from 20 to 30%, and in the elderly, maybe as much as a 50% mortality within 72 hours. And then complicating things further, in some environments, when you miss acute coronary syndrome, you end up being thrown into the med-mal arena. And there's a lot of legal groups out there that are pretty much entirely based on just missed cases of acute coronary syndrome. The circled area at the top says missed heart attack attorneys. This entire group focuses on missed heart attacks. It's amazing how much money there is in the med-mal arena for missed acute coronary syndrome. And in our specialty of emergency medicine, 20% of all the money we pay out for malpractice in this specialty is for missed cases of acute coronary syndrome. And when you look at this literature, the vast majority of these cases are based on simple things, simple misses in the history, and also simple misses in the electrocardiogram. Very, very few of these cases, if any, are focused on why you didn't get an electron beam CT or why you didn't get an immediate nuclear medicine or sestamib scan. So high tech is not where the med-mal occurs. Low tech, simple things are where the med-mal occurs, and that's what this lecture is all about. So we're going to spend some time talking really about the history. In the interest of time, we're not going to spend time on the EKG. We're just going to focus on the history, which again accounts for the vast majority of these missed cases. So why exactly are we missing ACS? Let's start out with something really, really simple, and that is the history. Now, I know you're watching this conference thinking that, gosh, I wanted to be learning about some really advanced topics, and I'm actually taking you all the way back to medical school. I'm going to talk about some real basics, because history counts for a lot of these misses. And this is something that I've seen in a lot of litigation cases, even just in the past few years. I don't know if it's some new technique that Dr. Bond was talking about, these courses that the attorneys go to. Maybe this is something that they're starting to teach in some of these courses on how to sue doctors, but this is something that I've been seeing as a theme over the past couple of years in a lot of these cases. And what I've seen is that in these cases where I've had an opportunity to serve as a consultant, what I see these attorneys do is to go after the physicians based on misses in the simple history of present illness. Take this first statement. This is from right out of a deposition. Doctor, are you familiar with the OPQRST mnemonic? So this physician had sent home a patient who ended up dying of acute coronary syndrome. They looked at the chart and noticed that there wasn't a lot written in the chart. They said, Doctor, are you familiar with this mnemonic? This is something that you learned in medical school? The doctor says, of course, I learned this mnemonic in medical school. It stands for onset, precipitating factors, quality, radiation, severity, timing. These are all good questions to ask somebody who presents with pain. So then the attorney says, Doctor, you teach your residents and medical students to do a good history. Isn't that right? Isn't that what the OPQRST is all about? Yeah, I teach them to do good history. Doctor, why is it important to do a good history? What would you say? Well, it's important to do good history because it narrows down your diagnosis. And then one by one, the attorney went through this OPQRST and showed the chart that this doctor himself had written up and said, "Doctor, show me on this chart where you talked about the onset of the patient's pain. Doctor, show me on this chart where you talked about the quality. Show me on this chart where you talked about the severity." Of course, all of these things are missing. Doctor, a few minutes ago, you said that it's so important to do a good history because it narrows your differential. It helps you with the diagnosis. And this is something that you learned in medical school. OPQRST, show me on your chart where you went through these things that even the medical students you work with are taught. All right, sorry folks, we're having a little technical difficulty, but where I left off, we were talking about the old car mnemonic, which is a mnemonic that I've taught so many students and residents over the years. And when it was my turn to go up to serve as the defense consulting physician, the plaintiff attorney puts the Dr. Smith's chart in front of me and says, "Dr. Mattu, I know you've been teaching old car to your students and residents for years and years. Show me on Dr. Smith's chart where he asked about the onset. Show me where Dr. Smith asked about the duration, the character of pain, where the pain gets better, what makes the pain worse, and so on." And every one of these things are missing from this chart. It was a very, very scantily written up chart. And you can just imagine my sinking feeling. I'm trying to help defend this physician in this lawsuit. And the very basic things that I teach the students and residents this physician didn't incorporate, the very basic things that we all are taught in medical school are not part of this chart. What we know is that in general, juries tend to be forgiving of physicians for being human. Juries accept the fact that we are not always perfect, that we're not always right, but in general, juries are not willing to accept that physicians are not thorough, that we're cutting corners. And when you do a shoddy history of present illness, one of the most basic things we all learn as second-year medical students, juries are not willing to accept that. So you've got to document a good HPI. Now, we all know that the history of present illness is not perfect. It's neither perfectly sensitive nor perfectly specific, but in every accelerated diagnostic protocol that's out there, it is an important part of what we do. Even the heart score, which is probably the most popular accelerated diagnostic protocol, remember the heart score consists of 5 components. The first component, the H, is history. So 1/5 of this score is based on simply doing a good history. So please do a good history. And if you do a good history and you document a good history, you won't even know how many cases other people look at and throw out. Because when they see a well-documented chart, a lot of those cases never even make it to deposition. So please, starting with the basics, make sure you document a good history. This says, even though the plaintiff is fully recovered, just think how much he can enjoy his health if you make him rich, right? A common mindset perhaps in many U.S. Juries. Okay, what's the most common misdiagnosis sitting on the chart of a malpractice case for a missed case of acute coronary syndrome? Most people know it's reflux esophagitis or peptic ulcer disease. There's really a lot of reasons why reflux is so commonly listed as a misdiagnosis and why it's so easy for us to misdiagnose patients as having reflux. Everything I'm about to show you on this slide is published right out of the cardiology literature. Studies have shown over the years that up to 50% of patients that are having an MI will report an increase in belching. 20% of patients will describe their MI pain as burning or indigestion, which misleads us into thinking it's just reflux rather than the classic crushing or pressure. 15% of ACS patients will get some improvement with antacids. About 7% get complete relief of their pain with antacids. And I always tell our residents, I've coded 2 people in my life who still had a mouthful of the white chalky Maalox in their mouth because they thought they were having reflux and they were pounding down the Maalox before they had their cardiac arrest. Please don't ever assume that if the pain gets better with Maalox or resolves with antacids, that rules out ACS. Large European study, over 10,000 patients, showed that 8% of patients in the study who had proven MIs had their pain begin during a meal. You know, Mr. Jones was just eating some spicy jambalaya when his pain began, so it's got to be reflux. Wrong. A lot of those patients actually can be having MIs. And the GI literature indicates that a lot of patients with proven coronary disease will also have GERD and vice versa. These 2 diseases coexist in a lot of patients. You know, interestingly, last Thanksgiving, we had a little downtime during a shift, and so we were looking stuff up on the internet, and we found some literature indicating that after a heavy meal, for example, at Thanksgiving dinner, in the first 6 hours after a heavy meal, your risk of having an MI increases 4 to 6-fold. So even a heavy meal, the very thing that you would most likely think, they just ate a big Thanksgiving meal, it's got to be reflux. please check a 12-lead EKG and don't ever assume that you're just looking at. One of the things that I've taught my residents for years, before you ever send somebody home with the diagnosis of reflux, just do yourself a favor and slap yourself, because if you don't, somebody else will. All right, moving forward. It's a little bit painful to watch that. All right, failure to appreciate ACS in young patients is another increasingly common pitfall. I'll tell you, when I was in medical school, I was taught that you have to be a 65-year-old man, or 65-year-old woman, or a 55-year-old man to have a heart attack. And then when I got to residency, they said, drop those by 10 years. So 45-year-old man, 55-year-old woman. And then I got out of residency and I started seeing more and more people in their 40s and 30s, and now even in their 20s, and even an occasional late teen who has a true atherosclerotic MI. Again, this is something that is a mistake that we've all made, because we've all learned that only older patients have MIs, yet a lot of younger patients have MIs also. What you're seeing up here, this data up here is probably about 10 or 15 years old, and it's gotten even worse. So don't assume that all of these are just cocaine, and if somebody's not using cocaine, they're off the hook. No, 5 to 10% of MIs are occurring in relatively young patients. This is not new data either. They've actually known this. Pathologists have known about this since the 1950s and 1960s, where they did autopsies on soldiers that were killed in the Korean and Vietnam Wars. Now think about this for a second. These are young, healthy men in the prime of their life, 18, 19, 20 years old. They're running around the battlefield with 50-pound backpacks on their back. These are incredibly healthy young men. They get killed in combat, and they get autopsies, and they're discovered to have significant atherosclerotic disease. 1950s and 1960s. Move forward to 1993. This is a pathology study that was published in Journal of American College of Cardiology in 1993, where they looked at over 100 young patients, average age 26 years old, that were victims of inner-city gang violence. So they got killed in inner-city combat, and they had autopsies. And take a look. Average age 26 years old, 3/4 of them had significant atherosclerotic disease. 20% had multi-vessel disease. Average age 26 years old. And again, this is 20, 30 years ago, long before our current god-awful diets that young people have now. There's another study from 2005, over 1,000 patients, 98% follow-up. That's amazing follow-up. They excluded all of the cocaine users. So again, don't assume that these are all people using cocaine. Non-cocaine users, 98% follow-up. What they found, 2% of these patients had adverse cardiac events, including death, MI, or need for cardiac bypass or emergent intervention. 2%. 2% doesn't sound like a lot, but we're talking about young people, right? So you can never rule this out just based on someone's age. And this has been in the pathology literature for decades now, since 1950s and 1960s. What do they say about pathologists? Pathologists know everything. Always just a day too late, right? But this is something that we have to be aware of. All of you out there that practice pediatrics or see a lot of kids, you know what kids nowadays are eating. The American diet, the Western diet has just deteriorated to unbelievable levels. And I was like mentioning this statistic, it's just an unbelievable statistic. Think about this for just a second. This right now, our kids right now, represent the first generation in human history that is expected to have a shorter lifespan than their parents. First time in human history, our kids, because of their current diet, are expected to live shorter lives than their parents. It's just an incredible statistic. In fact, about 10, 15 years ago, there was actually a debate that was staged within the American Academy of Pediatrics and the cardiology community, asking whether we as a society in the US, whether we as a society should be routinely starting our kids on statins. And they decided that, you know what, it's still maybe a little bit too early. Despite that, 10 years ago, pediatricians were already prescribing millions of prescriptions to statins for hyperlipidemia and hypercholesterolemia in kids. That was 10 years ago, and it's only gotten worse. And those of you that just practice emergency medicine, myself included, are maybe totally oblivious to this, but talk to your pediatricians and they can give you a little bit of eye-opening information about how common hyperlipidemia is. And the result is that a lot of pediatric cardiologists are now predicting that in the coming decade, we're probably going to be seeing more late teenager aged patients than ever before with true atherosclerotic related STEMIs. Whenever I give this lecture to large audiences, I always ask people, what's the youngest age of MI that you've seen before. I'm not talking about congenital problems or drug-related things. I'm talking about true atherosclerosis STEMIs. And in every audience of, I'd say, at least 20 or 30 people, there's always people that raise their hand, and say they've seen people in their early 20s. And if I get an audience of about 100 people, there's always at least a half dozen people that have seen teenagers with true atherosclerotic related STEMIs. And this is just increasing in number. All right, what's the next pearl we're going to talk about? Let's talk about ACS in women. Now, when I just mentioned that phrase, ACS in women, I'd imagine this is probably the picture you have in your mind. It's an elderly woman clutching her chest, very classic Hollywood type of presentation. She looks sick, she's a little bit pale, but that's actually classic. And just like Dr. Bond said a little while ago, classic means it's not that common. Classic means it shows up on the boards, it's in the textbooks, but in real life, this is what we're seeing. We're seeing younger aged women with atypical locations of pain, isolated shoulder pain, upper abdominal pain, and we have a tremendous failure to appreciate ACS in atypical presentations in women. This has been published for more than 20 years now in every major cardiology journal, every ethnic group, every cardiology society around the world has been publishing on this topic. It's gotten into the internal medicine literature and now starting to make its way into the emergency medicine literature, but it's not a commonly known thing. Premenopausal can and often do have true atherosclerotic disease, including acute coronary syndrome. And part of the reason that we miss this so often is that we've all learned that premenopausal women are not at risk. That's a myth. They are at risk. And on top of that, compounding the reason why we miss these patients is that painless presentations are more common in women, atypical locations of pain. Radiation to the right side is more common in women than in men. When I was in residency, I was taught that if the pain radiates to the left side, it's ACS. If the pain radiates to the right side, it's not ACS, which is completely wrong. There's at least 4 studies that say true ACS pain radiates to the right side more often than to the left side. But if you don't know that literature, you might very well be likely to think that if the pain radiates to the right side, it's not cardiac, and that does happen more often in women, radiation to the right side, more often in women than in men. On top of that, women tend to present with more symptoms and more vague type of symptoms. Weakness and fatigue for no good reason, achiness, flu type of symptoms. And the irony here is that women more often end up being misdiagnosed as having the flu or viral syndrome than men because they present with more symptoms, many of which are very vague. And this is not just true for elderly women, this is also true for younger women. And worst of all, younger women oftentimes tend to have a higher morbidity and mortality compared to their male counterparts at that age, again, because we tend to underestimate the likelihood of ACS in young women. This is a study that was part of the LLSA reading about 10, 15 years ago that all board-certified emergency physicians had to read. And this was eye-opening to many of us, where they looked at a lot of women that had MIs and they looked at the prodromal symptoms. Take a look at this. Only 30% of the women in this study had any chest discomfort. Now, that's a little bit of an outlier, because most of the studies out there still do say that most women that are having ACS will have chest pain, but not as often as men. Some of the other stuff that you see on this slide is not an outlier. 42% of women presented with shortness of breath as their chief complaint. Remember, shortness of breath is the most common anginal equivalent, that phrase meaning an alternative symptom to chest pain. Somebody comes in with shortness of breath without a good reason for shortness of breath, get an EKG. I'm not saying you need to activate the cath lab, but at least get a 12 lead. You'll be surprised how often you end up picking up ischemia. And then the other thing that shows up very commonly in elderly and diabetics, and especially in women, is sleep disturbance and fatigue for no good reason. Mom usually has so much energy, but she got up this morning and just had no energy. She felt wiped out. Or, Doc, I don't know what's going on, but I've just been feeling really, really wiped out the past few days. I don't have a good reason for it. Check a 12-lead ECG. You'll be surprised you pick up ischemia. And I've seen that in some of those med-mal cases that I've consulted in, where the primary complaint, the primary reason that the woman went to see a doctor in the emergency department was just unexplained severe fatigue. And I've joked about this before, but as I've gotten more experienced in emergency medicine, and in fact, as I've gotten more experienced in life, I've come to fear tired women. I'll just leave that with you right there, right? I saw Lean yawn a little while ago, and it really scared me, Liam. So please at least just check a 12-lead EKG if you have somebody showing up with unexplained fatigue. I'm not even saying that you need to automatically send troponins. Just check a 12-lead. It's a piece of paper with ink on it, for God's sakes, and it might just save a life. Let's talk about upper abdominal pain. Remember, the diaphragm's not a concrete wall. So anything in the chest can produce upper abdominal pain, just the way anything in the belly can produce chest pain. And if you've practiced long enough, you've seen lower lobe pneumonias, lower lobe PEs, pleural effusions all present with upper abdominal pain. Cardiac complaints, cardiac issues, ischemia can present with upper abdominal pain as well. And here's the key. If somebody's complaining of upper abdominal pain, but they don't have significant tenderness to explain it, check a 12-lead. Again, I'm not saying to do anything more than that up front. All I'm saying is at least check a 12-lead if they have no significant tenderness. If they're complaining of upper abdominal pain and they've clearly got a tender belly, then fine. You know, no rush to get the EKG probably. But if they're complaining of upper abdominal pain and you push on their belly and it's not tender, then at least check a 12-lead. This is a classic case here. Take a look at this. This is a piece of cake inferior wall STEMI. This was a 38-year-old woman who had known gallstones, and she came into the emergency department midday with some upper abdominal pain and nausea. She came in with a chief complaint, "Doc, my gallstones are acting up." So the emergency physician said, nausea, upper abdominal pain. He documented non-tender belly, but she's got upper abdominal pain. He checks a couple labs. The white count's a little bit elevated for whatever the white count's worth. He says, well, it kind of sounds like it's a cholecystitis. So he sends her for an ultrasound. Ultrasound comes back. She's got gallstones, maybe some non-specific sludge or something. I mean, it's not clearly cholecystitis, but gallstones, nausea, upper abdominal pain. They call surgery. Surgery comes down. They're not busy. They say, all right, fine. We'll take the gallbladder out. So they send a bunch of pre-op labs. They get a pre-op EKG. Nobody looked at it. Not the emergency physician, not the surgeon, not the anesthesiologist. She was having inferior STEMI the entire time. Nobody looked at it. They took her up to the operating room and opened her up, and under the stress of the surgery, she coded and died on the operating room table. And then later on, they're reviewing the case afterwards, and they found this EKG that nobody looked at, and they said, oh my God, she was having an inferior wall the whole time. She had upper abdominal pain, but no tenderness. And because she had a history of a gallstone, everyone assumed it was cholecystitis. This would have been a piece of cake, inferior wall STEMI to treat, but nobody looked at it. It's a very nice case, just demonstrating the classic thing that we're talking about, that MIs can present with upper abdominal pain, as this patient ended up doing. It says, Your Honor, before we settle on a judgment amount, we'd like to know how much money there is in the universe, which is kind of about what this case ended up settling as. One of the last pearls that we're going to finish up with is over-reliance on troponins. This has become very, very common. It's really become a troponin world, and people have gone way overboard in relying on troponins. I'm seeing cases where patients have positive EKGs, but people are ignoring it because of negative troponins. They have very concerning histories that are totally being ignored because the troponins are negative. Please remember, troponins are not all that. Troponins are pretty good when they're positive, but you can still have negative troponins in the setting of ischemia. And this is a great article from out of JAMA's Rational Clinical Series. They reviewed the world's literature, and they came up with a lot of great recommendations and statistics about ACS. One of the key things to me that came from this article was this simple concept: biomarker negative ACS still exists. In other words, you can still have ACS even with negative troponins. Take a look at this case. Nothing happened bad in this case. This was a good outcome, but just take a look at this EKG. This is a god-awful EKG. There's ST depression everywhere, ST elevation in AVR. This patient ended up having diffuse ischemia with triple vessel disease. 90-year-old woman who's got chest pain, nausea, shortness of breath. 90-year-old woman comes to my emergency department. I don't care if she's visiting somebody. I'm admitting her, right? So she's automatically going to be admitted with this story. And on top of that, she's got a very positive EKG. And I don't have the baseline EKG, but I'll tell you, all of the EKG abnormalities you're looking at here are new. So 90 years old, she's symptomatic, she's got all of these EKG abnormalities. She had 2 negative troponins 6 hours apart. So I'll ask you, how much can you rely on troponins? She ended up going for cath and had multivessel disease, and fortunately ended up having a pretty reasonable outcome. But this could have been a disaster if the EKG had not been so positive, because somebody could very easily have just relied on those negative troponins. And remember, every accelerated diagnostic protocol out there relies on three things: a good history, scrutiny of the 12 lead, and troponins. There's never been a single validated accelerated diagnostic protocol ever which only says all you need are troponins. Every accelerated diagnostic protocol out there involves not just troponins, but you've got to scrutinize that 12 lead and you've got to focus on that history also. And remember, if you are using accelerated diagnostic protocol, whether it's the heart score or the ADAPT score or the EDAC score, number one, make sure you're using one that's been externally validated. The heart, ADAPT, EDAC's probably amongst the best. And use it the way it was published. Don't go rogue with these scores. Don't just focus on the troponins. Use these protocols the way they were originally intended. And by the way, all of the attorneys out there know about these protocols. And my experience is that they all know about the heart score now. Every one of them asks you, are you using the heart score? And if you say yes, you're using the heart score, they're going to take you through that heart score and have you add up all the points, and you better know what the points were, right? Or same thing for EDACs or anything else. So let's just sum up what we've talked about. It's an interesting billboard to show you how attorneys think. Just because you did it doesn't mean you're guilty. Great. All right, let's go through some take-home points here. Number one, please do and document a really good HPI. It'll save you from a lot of cases. It truly, truly will. Do not exclude ACS purely based on the presence of reflux symptoms, or purely based on young age, purely based on female gender. Even young women are going to be at risk if they have a concerning HPI or EKG. Don't exclude ACS purely based on abdominal pain if the belly is non-tender, and don't exclude ACS purely based on negative troponins. And if you're going to use an accelerated diagnostic protocol, make sure you're using it the way it was published, and also make sure you're using an externally validated one. And I think the best ones out there are the heart score and the EDAX score. There's a couple others that are showing promise, but I'd say those probably have the best literature to support them. And with that, I will conclude and open it up to any questions before we finish things up with the final POCUS lecture.
As always, great talk.
Microphone.
I'm on the left.
Oh, okay.
So somebody wanted you to comment a little bit more about the EDAC, TMAX versus the heart score, and which one would you use?
Sure. So heart score versus the TMAX versus the EDAC score. The TMAX score is a recently published score from London, and it's only been studied, to my knowledge, it's only been studied in the UK, and it has not yet been externally validated. That's what was in my mind when I said that there's new, very promising ones that are up and coming. So I'm not using the TMAX score, and I'm not going to until I see an external validation. External validation means you could come up with a rule and then validate it yourself in your own population, and that's great. But until somebody in another part of the country or another part of the world does the same study and comes up with just as good results, that's called external validation. Until that happens, then I'm not going to use the TMAX score. I bet it will be externally validated. I bet it's fantastic, but I'm waiting on that. The heart score and the EDAC score have both been well studied, are both externally validated, and I think both of those are fantastic. I would say take your pick. Here at university, we've been using the heart score for a number of years. After recent external studies have come out supporting the EDAC score, we are now putting together a protocol that will allow EDAC score to be used, and I'm already using the EDAC score. So if I see a patient coming in, I'll just take my pick. I'll use either the heart or the EDACs. I'll document that I used it, and I think either one is very, very defensible. Those are the two that I would use, and we'll see how further studies on the TMAX score come out.
Actually, you had a good segue to the next question is, how defensible is it? So let's say I do a heart score, and it's negative. I discharge the patient, and then he had a bad outcome or he dropped dead.
Yeah, so if you use one of these externally validated scores and you get a low enough score to discharge, and somehow there's a bad outcome, which again is going to happen in probably somewhat less than 1%, but 0.8, 0.9%, it's going to happen. Nothing's 100%. I think they're extremely, extremely defensible if you've documented that you used a score and added up the points properly. I think it's very, very defensible, and you've got a lot of literature worldwide to back you up.
There was a question that came up about high sensitivity troponin versus just repeat troponins. Anyone better than the other?
Sure. So the high sensitivity troponin is definitely more sensitive. It's a bit less specific, but it's more sensitive. And I think more and more people are moving towards the highly sensitive troponins. In terms of incorporating them with the heart score or the heart pathway, which involves two troponins, what we do here is we might get a troponin at arrival and then repeat it in 3 hours. Once we get the highly sensitive troponin, which we don't have yet, but once we do, instead of the repeat in 3 hours, we might switch over to getting the repeat in 1 or 2 hours. So I think the highly sensitive troponin will decrease the amount of time that you have to wait before the repeat. It'll decrease it maybe to about 2 hours or so rather than waiting 3 hours. For those people that already have the highly sensitive troponin, you're probably able to get your patients out of the emergency department a little bit faster than if you just have the conventional troponins.
But you would
right
still
now.
repeat the high sensitivity troponin. You just not get one.
Yeah, the protocols, the published, validated protocols that are out there have essentially said that if a patient had an episode of pain more than several hours ago and they've been totally asymptomatic for the past few hours, and you get one highly sensitive troponin and that's negative, then you're done. But that is with the caveat that during the past few hours they really have been asymptomatic and their episode of pain was several hours ago. If they have ongoing pain when they come to the emergency department, I'd be more likely to still get the repeat.
Okay. Is there any evidence for or against fentanyl versus morphine in pain control in ACS?
So fentanyl versus morphine for pain control in ACS, there's very little data on fentanyl specifically. There is some data on morphine, and there's some suggestive evidence that morphine may inhibit the antiplatelet effects of clopidogrel, and some data suggesting that morphine, because of its histamine effect, may produce some slightly adverse hemodynamic consequences. So we're not big fans of morphine, and that's based on data that shows relatively, I think, small detrimental effects. Morphine is still in the national guidelines. It's been downgraded, from class 2A maybe to about 2B. So we're not big fans of morphine. My preference, if somebody needs an opiate for pain because nitro is not working, if I'm going to give an opiate, my preference is to use fentanyl, but that's not based on any good data. It's just based on the fact that fentanyl has less histamine release, and our supposition is that it's the histamine from morphine that's been causing the effects, but that's not based on any data. So you can still use morphine. It's supported in the guidelines. Our preference is to switch over to fentanyl when possible.
How are you documenting your decision making when they're low risk and in your mind, like a reassuring EKG, not very suspicious story, and you have 1 or 2 tropes that are negative? Like, how would you document your thought process, I guess?
I try to document the old car. So the old car goes in all my notes. Every one of those chest pain patients, I've documented all of those components. So I've documented a good negative review symptoms. We use the heart score here. Sometimes we'll use the EDAC score. So I'll document what their heart score or EDAC score are. And I'll just document based on heart score, patient is low risk, 3 points or less, and justifies discharge and follow-up, or EDAC score was used, patient's low risk, justifying outpatient follow-up. And essentially that's what we do. We just document the fact that we've used one of these externally validated scores.
And that's the language you would use?
What's that?
That was the language you would use?
That's pretty much the language, yeah. I mean, as long as you're saying we've used the heart score, people know what you're talking about. You say we've incorporated the EDAC score and the patient's low risk, I think then that would be universally understood.
Okay, and then one question here is about why do we repeat troponins in 3 hours if it rises in 6 hours? If the symptom onset, let's say, is like 30 minutes from presentation. So why do we do 3 hours?
Sure. So the current conventional troponins are a lot better than the older troponins that many of us trained with. When I was in residency, the first troponins that came out, you had to repeat them every 8 hours. And then the next generation came out, and then they said, yeah, you could probably repeat it every 6 hours. The current generation that we have, you could probably repeat it in 3 hours. And if the patient is not suffering from acute coronary syndrome, you'll see it rising. So the current troponins are pretty darn good. And the newest generation, which are called highly sensitive, is even a little bit better. But the current generation of troponins will start rising a lot earlier than they did 10, 15 years ago, which is what that 6 to 8 hour protocol really is based on, an older generation of troponin. And the current national guidelines say repeat the troponin in 3 to 6 hours. And so we've chosen to go with the 3 hours. And that, again, that's based on the fact that the current generation of troponins that most everybody has are pretty darn good, and clearly better than what we were using 10, 15 years ago.